Hi everyone, welcome. Thanks for joining us for the Kirby Institute seminar series. My name's Carolina Sandler. I'm a senior lecturer in the School of Health Sciences and part of the UNSW Fatigue Clinic and Research Program, working closely with Lucette. I'd like to begin by acknowledging the traditional custodians of the lands on which we're gathering today and pay my respect to their elders past and present. Today we're presenting from the Bidjigal people, from the land of the Bidjigal people of the Eora Nation, and I extend that respect to Aboriginal and Torres Strait Islanders people joining us here and in the audience and online. So some brief housekeeping to start off with. Unfortunately, Brendan had to cancel today, so hopefully he'll be able to present later in the series. And what we'll do today is Lucette will present, and then it'll be followed by a Q&A session online and in person. So if you're joining us online today, you can start asking questions throughout the talk. You can click the Q&A icon at the bottom of the screen. And for our audiences in the room today, the microphone will be available and we'll come around and ask your questions at the start of the Q&A session. So I want to introduce Associate Professor Lucette Cysique. I always say it wrong, Lucette, sorry. Lucette is a cross-disciplinary neuropsychologist who leads a research program into the brain health of major infectious diseases across several institutions, the Kirby Institute, the School of Psychology here in UNSW, St Michael's Hospital in Toronto in Canada, and St Vincent's Hospital Sydney campus. She's also a co-investigator on the Doherty Institute-based APPRISE long COVID initiative, which aims to describe long COVID disease burden in Australia using the well-recognised post-infective fatigue syndrome framework. So please welcome Lucette.
Thank you very much. Thank you so much, Sam. Thank you very much for this very nice introduction, Carolina. And with no further ado, I'm going to start. So I'm going to present a review of the long COVID Australian research, try to highlight some of the lessons we've learned, and also some recommendation for research, including across international settings. Carolina just did the acknowledgement. I just don't want to repeat it. It sounds a little bit over the top, but at the same time, for me, it's very important to have this slide to recognize custodianship of Aboriginal people. The APPRISE Long COVID is actually a preparedness network based at the at the Doherty Institute in Melbourne. It is led by Professor Lena Sanchi and Professor Andrew Lloyd, who's here at the Kirby. And so, of course, we have a larger team, which I'm part of, and we also have students who have joined us this year. The aim of the APPRISE mapping project. So within the APPRISE, we've got two flagship projects, the mapping and the cohort study. So the mapping, this is what we're talking today about. So the mapping project first aim is to identify all existing current and completed prospective cohort and nested cross-sectional studies and describe outcomes, including which long COVID definition was used and how it was operationalized. The second aim is to assess the quality of each study using the modified Joanna Brigg Institute scale in reference to the APPRISE long COVID research case definition, which I'm going to give you a background on. And then what we aim to do as well is to verify the long COVID caseness in adults and children in partnership with the original cohort investigators or cross-sectional study investigators, and in reference again to that long COVID APPRISE definition. And so we've elected to do this only in the studies that we're going to rate as high quality. And I'll explain that as well. So the first part of the project is really a standard systematic review, which we have registered the protocol for with Prospero, and we use standard guidelines such as PRISMA and STROBE. We've done some standard search strategies, and we were really helped by existing database and registers that themselves already filtered for COVID or even long COVID content. And I will show you how it pans out. But we've looked at international registers and we went into Australian based resources, such as a governmental report and the APPRISE Biobank, for example. And we also covered community websites. And of course, the grey literature. So the search was started from 1st of January 2020 and for 4 years. We restricted to English language and human population. And as I said, we have those predefined COVID filters of different size and specificity, but they were absolutely fantastic, and they can be copied and pasted across different resources. So in other words, when that was possible, we applied it across the different sources. And so that really helped us to filter very quickly the appropriate content. In terms of inclusion and exclusion criteria, we were fairly inclusive because the idea was to rate the quality. So the first inclusion criteria really repeats the first M. And we were also, we had that extra criteria where we sometimes we have those subclinical or specific population that are studied, but we want to make sure that the way the study was done made it still interpretable to look separately at long COVID or COVID-related symptomatology. And then in terms of exclusion, we excluded trials, study investigator that could not be reached after multiple attempts. So for example, I'll give you an example. We had to ask some international investigator how many Australian were in their study, for example, because it was a multi-site study that included Australian cases. So in some cases, we didn't have a response. I mean, it was rare actually internationally, but I think more commonly what would happen, the investigator would tell us they were not able to provide specific data just on Australians only. So that's, for example, one case. I'm just citing one case there. And the other situation was where the authors replied back to us, for example, but they would say, well, our data is not ready for being published yet. So there's one study like that. So I've already said that we've used the standard guideline PRISMA strobe, and for all the collection of outcome, we used a combination of cross-sectional, longitudinal, observational cohort and case control study, cross-sectional study design tools to collect the data. So we ended up with less than 1,000 relevant records, which is usually, it's pretty good because usually it's more like in the 10,000s. So it was because of those filters across the databases and the registers. And we also looked at those website organization, meaning the governmental report, and the citation share sheets 20. So overall, we looked into that, and we found that 28 needed to be more specifically looked at, like reading the full manuscript, etc. And we elected 19 studies that were eligible for our review. And so out of those 19 studies, one of them actually is a database from Western Australia. So we don't have access to that yet because I'll explain, we've done an ethics application to be able to request what's exactly in the database. So for now, you should think 18 rather than 19, but I just want it to be transparent. In terms of the APPRISE long COVID definition, so the background is as follows. So, and that's something that comes from the post-infective fatigue framework, which we have probably our senior representative here, Professor Lloyd. So the idea is, the rationale is that the original definition of long COVID, such as the WHO, NICE, CDC that you are probably aware of, are definitely clinical definitions. They have the advantages, especially early on during the pandemic, in terms of trying to define clinically the condition. However, they lacked in strictness, and so they are not suitable for research, which require more robust criterion and construct validity. So criterion validity, so high level of specificity and sensitivity, and criterion validity, looking at specific construct or key symptom domain or that reflects, that are linked to the disease itself rather than something else. So the APPRISE long COVID definition try to actually overcome this lack of strictness, and is a modified definition of the WHO, in the sense that it still marked the disease at 12 weeks or 3 months post-infection, and it improves that sensitivity and specificity to the COVID-related persistent symptoms. So it actually specifies a longitudinal assessment in other terms. The modification are informed, as I said, by the post-infective fatigue syndrome, which I often refer PIFS, but I will spell it out in the context of the talk. And what's important is that this framework has established criteria for a range of post-infective illnesses, and the research dating back to before even the 1990s. So I remember even reading an article done in the 50s about post-infective illnesses. So I think it's important to look back at this research, because it has gone through the same step as we're going through with long COVID. And also this research has been informed by the community. A lot of the work that has been done in establishing those criteria were informed and by consulting the community. What's important about the criteria that exist is that they necessitate careful and exclusion of medical or psychiatric condition that can better explain the post-acute symptom by history, clinical examination, and protocolized investigation. And I will go into details. So we have a 3-part definition that can be used not only for new onset infection, but can also be retrospectively applied to research studies or even clinics, as we are doing in that mapping project. So it's robust enough to be used in research, but can also use, in fact, in primary care. That's kind of its strengths as well. If followed carefully by primary care, like we're trying to do in the outpost, it can definitely be done. And it may be supplemented by sort of a more specific assessment, which include a semi-structured interview, which characterize the fatigue states and related symptoms and associated disability in secondary case definition, which is what we refer as chronic fatigue syndrome, fibromyalgia, with and without, for example, comorbid mood disorder. And I'll explain a bit more about that. So just to be clear about the 3-step definition, part 1 is really the confirmation of acute infection. And so that actually sounds like obvious and evident, but actually if you look at the international research, a lot of people have not made that quite clear. So it's great to have PCR or even those very sensitive rat that we can use today, or a probable acute infection with an influenza-like illness in a higher risk epidemiological context. So that's the level of strictness of the definition there. Primary case definition, that is the W modified long COVID definition, research case definition, as I said, at 12 weeks. So criteria 1, new onset of ongoing symptom, includes at least 1 of fatigue, shortness of breath, cognitive disturbance, and sleep disturbance. And this is actually quite, I'm one of the person who think it's quite generous, because typically we know, I mean, the post-infective fatigue framework research shows that those symptoms tend to cluster. There may be a profile that's more cognitive and a profile that's more physical, but it's going to be very rare to have fatigue only with nothing else. It's going to be very rare. But in any case, so what's really important as well is that we require a substantial impact on everyday functioning. And I think that marks sort of not only the sensitivity and specificity of the definition here, but also its clinical significance. And so no symptom-free interval from acute infection, and that's a big difference from the WHO definition. And that has been argued, but when you look carefully at cases, and you've seen enough cases, you can see some level of mild recovery or good recovery from acute infection. But actually, when you look very, very carefully, people do report symptoms across that 3-month period when they actually match the caseness. They don't just become super well again. It's just it would be very rare. Additional symptoms such as myalgia, distress of smell, etc., can also co-occur. So there's no situation where all those other symptoms that have been mentioned, you know, the 150 symptoms are excluded. They're not excluded at all. They're included, but they do not pertain sort of to the core symptom diagnosis, which we know from the post-infective fatigue syndrome that they're always going to be there. And the symptom can fluctuate over time. I think this seems a bit contradictory with the no symptom free interval, but it is not. So I think it fluctuates over time within the clinical threshold that we agree on. So people do not revert back to their best functioning, but so there can be still some level of fluctuation as well. And it's typical because when you get an acute infection, you get really sick and you've got this acute sickness. And then so what we call post-acute is somewhat different in quality and severity at this stage. And so what we do as well with the long COVID definition that we've published on the APPRISE website is that we recommend instrumentation. And this instrumentation is there on the website if you want to consult it. And it tells you what they are, their references, and what their clinical threshold are. Using clinical threshold as the advantage of avoiding, and I will talk a bit about that later on, it avoids bringing a whole level of normative level of symptoms that occurs across the population all the time. We always, if we take just the sample here in the room, I'm sure some of us are going to say they are fatigued. So that's okay, that's totally normal. But when we reach that higher threshold, we know that it's not only more likely to be clinically significant, but also it's more likely to be related to some pathological mechanism that relates to the infection in that case. And then part 3, so which is probably certainly the most difficult and the most the one where there needs to be some medical, also actually a cross-disciplinary input, but definitely with a final medical decision, is to rule out other known cause of the symptom by clinical evaluation and investigation. And so the clinical investigation, actually, what we do there, we specify what should be looked at by default in a way. So it's not only physical, you need also ideally to look at the mental state of the person. And so careful history taking, meaning, you know, looking back and seeing if people have had different kind of medical condition that could explain better their symptom states. And so a set of minimum laboratory screens, and then additional investigation can be undertaken. And here there are some examples. I like to use the sleep apnea as a comorbidity or a concurrent potential differential diagnosis, because sleep apnea is very, very common. A lot of people have it and they don't know they have it. So when you, for example, you would go through this careful examination, and you could actually find out that people have had a fatigue state that's related to an untreated sleep apnea. And so that's why it would be really important for the people to see their primary care physician who know about the history there and would recommend a sleep exam, for example. And you would see that once this is treated, you could see that the fatigue state goes away. And so we were not having long COVID there. We had sleep apnea, for example. And it's just an example. Anyway, so that's it. And then the next one is in terms of potentially the research, but even in terms of a more specialized care, it is possible to further refine the definition of long COVID caseness across 4 different syndromal designation, which again really match different post-infective illness criteria, which have been published internationally. And for this, we use a semi-structured clinical interview called the skin structural clinical interview for neurasthenia. Neurasthenia being an old French term, I think, for fatigue. I think. Anyway, so the first one everybody recognizes is chronic fatigue syndrome, which really is characterized by fatigue and fatigability and post-exertional malaise. That's what I mean. Fibromyalgia, which is more fatigue, more like a physical fatigue involving muscles and joints. POTS, which is a bit a challenge for me to pronounce, postural orthostatic tachycardia syndrome. Not too bad, Lucette. Anyway, that one is more characterized by dizziness and palpitation, and especially when standing up, and then can be co-occurring or more explanatory major depressive disorder, which can really mimic sometimes fatigue states as well. That's it. And then the next slide, Lucette. So what we've done, we use all this framework and we've applied it to the long COVID research that we found, those 18 studies. So I don't expect you to read the slide, it's just to show you the level of evidence. So here, level of evidence. So what we've done, we've created different level of evidence. Level of evidence 1 for acute infection is PCR laboratory, top 1, level 1A. And then we rated in the studies, for example, people who just reported, or well, people self-reported that they had COVID in one day, or they had a febrile illness. So that's level 3, it's uncertain. And then we did the same with the long COVID definition. We used the reference, the confirm as the top level of evidence, the one that I've mentioned, which is modified WHO or NICE or CDC or like diagnostic criteria, with all the following undertaken. So the comprehensive history taking, the complete medical examination, the assessment of mental health, and the recommended laboratory investigation, and also assessment of ongoing symptoms across a certain period of time. That's critical, using the validated questionnaire that we've recommended, covering at least covering all the following: fatigue, shortness of breath, cognitive disturbance, sleep disturbance, but also functional changes and disability. And then clearly a clear algorithm where other causes were excluded. And so that would be the top one. And then the level 3, for example, it would be just, for example, people who it has been a lot of study done like that, and I don't want to diss everybody, but I think everybody was trying to respond very, very urgently. Okay, so it was hard to put everybody together. But for example, a study where people tick, I am fatigued, tick, I've got a sore joint, tick, etc. So when you have someone, if they're fatigued, they can understand so many different things. When you use a validated questionnaire to assess fatigue, your construct is much better assessed. So that's the idea behind all of this. And also what we've done, we've used the GBI and we input it in item 3 and 7 for the cohort study, and 4 and 8 for the cross-sectional study, the acute definition of each studies and the long COVID definition for each study. So it was rated that way. And then for the other part of the GBI questionnaire, we simply assess the quality of the study, and we define an overall score of 80, so about 80%, which means that we agreed to leave people with 1 or 2 items of medium or poor quality. So we thought that was general. I don't know, maybe I was too hard there or not enough, I don't know. Anyway, so doing this on those 18 studies, what we see is that the acute level of definition was pretty good across 12 studies. And there were 6 studies where, basically people just ask, were you sick or not, or something like that. And then the long level, the confidence in terms of the long COVID, we have sort of the reverse pattern where we had only 6 studies where the definition met our highest standard versus 12. And so when we looked more specifically at which study we're talking about, so in the cohort studies, we've got 25%, so 3 out of 12 that match at least the 80% criterion, which was the ADAPT, ADAPT at St. Vincent's Hospital, the Sydney Children's Hospital Network cohort by Philip Britton, and the Life After COVID study, which was in Victoria. And then we looked at the cross-sectional study, and we've got the South Australia Dysautonomia and Arrhythmia study, which is a group that specializes in POTS research in Adelaide. And then we've got the Queensland Griffith study, which was a pilot case study. But this one as well is a group that specializes in chronic fatigue research as well. So it's not surprising in a way. And so when we look more in depth at what's inside those long COVID studies that we rated as high quality, the first study, the long COVID the life after COVID reported 7% with fatigue. So they actually do not report their overall long COVID caseness. So that's where we can go and look at the investigator and say, oh, can we please, come together with some work? We're going to use all your outcome, because they actually picked up all the correct outcome and provide an overall point prevalence here. But in terms of the fatigue they report, so fatigue being one of the core symptoms, 7% of people having fatigue at 12 months. So it matched with actually it matches with international research that I use more sort of refined outcome for fatigue. And then there's a study from Phil Britton, the only children study, which is interesting. You will see, because when they looked at the questionnaire data across time with the parents and the kids, they found that 12% meet the case definition. But when they start to look at a much more strict definition and looking at very, very careful clinical review, they find that 1% actually match the long COVID caseness. So it shows the importance here of the medical clinical investigation. And then the ADAPT study. So this one is based on actually my own publication, where we had N equal 144 cases. And it is a definition that was critically improved in August 2023, when I contacted Andrew Lloyd, and Andrew said to me, no, you have to measure something that is meaningful in terms of impact. And so it was good, though, that this definition was strongly correlated with the other more biological APPRISE ADAPT definition. So what we see is that decrement over time that is typical of post-infective fatigue illness. So you'll see that in the other research that I'm going to show. What we'd like to do here with the ADAPT is that we know the ADAPT has data at 24 months. So that'd be great to be able to look at this time point. And yep, that's one thing that we'll try to do. And then in the cross-sectional study, so the one that is from South Australia with the POT specialist group, what they've done, they've compared people with long COVID, really strictly defined the way we would recommend. Then people with health who were healthy control, and people with POTS defined without having any acute infection. Or post-acutely from any infection. And what they find is that 79% of their long COVID case meet the POTS definition. So it shows this kind of strong hypothesis that from the post-infective syndrome that there's an overlapping symptomatology between the different post-infective illnesses. So that goes towards that. The limitation of that study is that the sample was small, and the way the long COVID cases were accrued were so a specialized clinic, and so that probably looked at only a certain type of cases, and it was early in the pandemic. All the Australian study are early in the pandemic, actually. And then the study from Griffiths, again, a relatively small study in terms of sample size. But what they've done there, they've looked at the cases whether they met the international consensus criteria for post-infective fatigue syndrome, the Canadian consensus criteria, or the Fukuda criteria. Fukuda done in 1994. And so what they show is that when they do that in their long COVID caseness, which is 100% under the WHO framework, is actually 23% with the ICC, 27% with the CCC, and with the Fukuda, which is the meanest of them all, 10%. Anyway, just to put this because I want to present this internationally as well through the group that I founded in the International Neuropsychological Society, the Neuro-COVID group. And so want to emphasize that when people use this framework, they tend to replicate, some of the key findings across different populations. So first here in Norway, the Norway cohort, that was done relatively early in the pandemic, that one. But what they've done, they've just asked people using, that post-infective fatigue syndrome framework, and then using 6 months point prevalence of the WHO modified long COVID definition. How many people had meet the criteria in people with SARS-CoV definite acute infection versus no infection. And in fact, there's almost no difference. So it shows that we got to be very careful how we define things. Otherwise, the noise is so high. I don't want noise to be a negative term here, but what I'm trying to say, the non-specific symptoms are so high that we cannot detect what we're interested in. And I think that's really important research-wise, but also even clinically wise. And then the next slide is another study, this one in the Netherlands, that shows really well this very important sort of peaking process around, post-infectively within 90 days. And actually, it's shorter within the Omicron variant. So the pink one is the Delta variant, and then the resolution across time. So again, that's why as well it's really important to conduct those longitudinal studies, because you want to be able to ideally assess from acute infection. And most of the Australian study that I've shown you have not done that, by the way. Anyway, so I think it's interesting to see that the Omicron variant here in that study, a very large study, by the way, the resolution of symptoms is before 90 days, and then they absolutely become indistinguishable from the uninfected control. I think that's interesting. And then on the right-hand side, this graph is kind of a combination of the two one before, but in another research setting. I think it's also in the Netherlands, but here they show the excess prevalence and 95% confidence interval of at least one of 13 post-acute symptoms in people who've had COVID. So it's a bit fuzzy, I apologize. But basically the red line at the bottom, the 0% is the background prevalence of those symptoms. And so all the other are the excess prevalence. And what it shows that in people who tested negative for COVID versus Omicron in purple versus Delta in pink. So earlier on, of course, the Delta has the largest symptomatology, but even then there's a resorption across time, and the Omicron even less so. And I think when you look at 12 months, basically there's a large overlap, meaning that the population, the symptomatology has mostly recovered, and they become less and less distinguishable from people who've tested negative in the first place. So again, the importance of both accurately circumscribing what we're measuring, but also doing it across time. That's critical. That's what the research shows. And so for the mapping project itself, we've got the ethics approval, so we're going to start to contact the study investigator of those high quality rated study, and we'll work with them to find what is most convenient to work together. And I guess one of the response to I think that, so the outpost was actually created before this assessment, but at the same time there was a sense from the expert that was needed anyway. And also the outpost is a response to what the community wanted. They wanted a study that was funded in primary care, because they're usually the front line of receiving those patients. So the outpost, and if you have a sniffle, do register. The posters are everywhere. Anyway, so we've made pretty posters, I think. I mean, I'm not the one who's done it. I can't take merit for that, but I think they're pretty cool. And so the outpost, just the objective, so that's the flagship study of the APPRISE, to describe the point prevalence and functional impact of long COVID in subject evaluated 12 weeks after confirmed SARS-CoV infection, and in comparison to other respiratory infection, as well as demographically matched and infected control. So that's the other thing that the Australian study have not done so well. I don't want to be too critical, because it was really hard to respond during a pandemic context, was to assess against other viruses. There's been a study who's done that, but the way they measured things was, a bit not specific enough anyway. And then, of course, to look at those secondary case definition, and we have other aims. I'm not going to go too much into it. I just want to show you how we do overall the study. So we accrue from a primary care population, and we really try to work right from the acute infection. I think that's critical, because we know that the severity is going to be a major factor for long COVID caseness. And so we match to a non-infective population as well. And so we look at people who SARS-CoV, people with influenza, A or B, or RSV, A and B, and then those controls. And then what we do, we ask people to write. So it's a bit of a challenge, I think, but we ask people to write their symptomatology across all those key areas that I've mentioned prior the infection, but as a memory exercise. But usually, so they can do it at any time in a way. So they can go back and so write their current infection the way they feel now. And during, that period where they're quite sick in a way, and they have the time to do it, we give them 2 weeks to do it. And then they can write against, how they were before. So I think it should be, for most people, it should be pretty clear in their mind. Then we do that again at week 6 and at week 12, and everything is done on REDCap. We have another sets of questionnaires that look more specifically at all these other symptoms. And I think it's important for a message for the community there that we're not underestimating the other symptom. We look at them as well. And then what we do, in the people who meet long COVID caseness through the computer algorithm, we then conduct that more in-depth semi-structural interview, where we can also define the secondary case definition. And then we have a clinical visit. So the patient can go to their primary care physician, and we recommend certain level of clinical investigation, etc. But also because the primary care physician knows the patient well, they can also require more specific examination if needed. This comes back to us, and then in a case conference, we confirm or infirm the long COVID caseness and its subtypes. And so this caseness algorithm can be also applied to the non-infective cases as well. At the moment, where we at with the outpost, we have 16% who meet the long COVID caseness. We call provisional because it's only through the self-report questionnaire. And so I'm about to start some of the structural, the skin assessment, and we'll know more specifically. We know that it will go down because that's just the nature of the beast. And so conclusion one, I think there is I would say more or less quite move towards this post-infective fatigue syndrome. It's coming back. People are just thinking, oh yeah, actually there's been 40+ years of research on that. It does make sense. It's more specific. It's stronger scientifically, and it's also been done in consultation with the community. So all this work has been done. Let's take advantage of it. And in terms of the Australian research, so we see that the clinical review substantially reduces long COVID prevalence in both adult and children. The only high quality or eligible children study in that cohort shows that long COVID may be rare in kids, and that matches some international research. In adults, we show again that the Australian research shows that there's a reduction of symptom over time, but we have not covered the acute period, and studies were unequal in their qualities. Australian research from a group with expertise in ME, CSF, POTS, etc., do tend to confirm that the post-infective fatigue syndrome shares symptomatology, and that would include long COVID, although those samples were small and cohort self-selected. The Australian results, however, were mostly from the Delta era and early Omicron era. So this gives still space for a cohort that's well constructed in the current era, vaccinated era, and late Omicron era. And actually, we've got a new variant, you're probably aware of that, with comparison to other respiratory and uninfected cases. And so it looks like using the established framework of the post-infective fatigue syndrome should be recommended, and would inform not only a better appreciation of COVID and long COVID, but also would help to prepare for a future pandemic. Although in each case, we have to review exactly what the virus is doing, of course. So the message from the community, hopefully received positively. It is important to specifically diagnose for long COVID and other post-infective syndromes versus other medical conditions to receive targeted care, because you understand there's a really overlap in symptomatology. And for the more healthcare professional, the more healthcare professional are aware of the existing guidelines, the less likely diagnosis will be delayed, which is a major issue in the field, and the more likely intervention will be beneficial. And research-wise, the more we have something that like a core knowledge on an actual illness, the more likely we'll have biomarkers and therapeutic discovery that's going to be targeted and will be funded in a stronger basis. And I've talked a lot, I think. What time is it? Thank you for your attention. Oh yeah, 40 minutes.
That's right, you got excited. It's good, Lucette. So I'm going to open up the floor. Yes, let's go for it.
Thanks. That was really interesting, Lucette. Thank you for that. The Outpost study, I may have missed it, and so I'm just clarifying. You're recruiting through clinics?
So no, actually, it's not like that. So what we do, we advertise our study as broadly as possible, but through the primary care clinic serves as beacons. We put it's like we put our flag in that primary care clinic and around the pharmacies, and so like a catchment area, and then we advertise the study, and then people can self-register on that, those posters and on the social media as well. They click on that QR code, and they get sent to the website. And on the website, they go through a screen, and if they're eligible, then they can register to receive a rat test. Then if they test positive, they can follow on the study questionnaire.
Right. So they don't actually need to be seen by those clinicians that are participating then, I guess.
No,
right.
No, it's not a prerequisite.
Right. Yeah.
Sorry, maybe there was
no. Like I was going to point out something that I'm sure you're aware of, that obviously people that are not as sick won't be presenting, obviously. So missing a population.
So we exactly.
Yeah.
So we had this discussion many times, and so the idea was to be really trying to catch the general population rather than only the one who would present. Probably would be a bit different at the clinic.
Yeah.
But at the same time, we knew that people who are sick actually they're told by the GP not to come to the clinics. So we've got other ways of recruiting through social media, radio, and we even have a beautiful radio pitch from Andrew trying to recruit people in the Blue Mountain.
If I could ask one more question, maybe, is the rates that you showed of long COVID for the ADAPT study, for example, compared to the other studies, there was a couple of them which showed around 26% with fatigue syndrome. And is there there's a lot of definitions that you used, obviously, which you've filtered through and I haven't managed. But what is the key? Have you thought about why it's so different between that and the other studies that were looking at about 12% or 10%?
Again, I think some of the difference is definitely related to that clinical review and how the clinical review was done. As far as I'm aware, in the ADAPT, and I don't want to criticize the ADAPT because actually it's one of the high quality rated studies, so it's very good. But as far as I'm aware, and it was very early, so there was an emergency response in a way. But the clinical investigation of the medical visit did not involve a thorough mental status examination. So I remember that we, the psychologist and the other people, we would give some scales to the participant. But how was that exactly linked to the medical examination? I'm not sure. Yeah. So that would be one explanation, for example. Yeah. The other explanation was it was Delta and everybody was unvaccinated. Maybe a stronger explanation, that one. Yeah. Anthony.
Lucette, thanks very much. So just about your definition, and I guess it may be less important for your current study, but when you're comparing it to the literature. So how do you account for the severity of COVID? So if someone's particularly in that early stage ends up in intensive care with, bilateral pneumonia and has an ILD or has had pulmonary emboli and stuff, then so that's obviously a complication of COVID, but whether that sort of fits, there's going to be a prolonged recovery from that, as there would be with any person in intensive care with those conditions, whether it's from a bacterial pneumonia or from just recurrent PEs or whatever it is. So how do you account for that sort of damage, I guess?
Yeah, that's a great question. Thank you very much. That's probably the first, when I talked to Andrew in August 2023, that's one of the first talk we had about that. Because neuropsychologically at the time, I was like, well, that just might be long COVID, except it was caused by something different. But then discussing with Andrew and the post-infective fatigue syndrome framework, it really takes a different approach to that. What it says that if there's an acute related organ damage that it's severe enough, it supersedes probably in its symptomatology what we're gonna call being long COVID eventually. So for example, if someone has a stroke, what we're gonna see is the stroke impact, the damage of the stroke, rather than, and it's what I'm trying to talk like Andrew, it's a medically, in that case, the symptomatology that we see is a medically explained cause of the symptom. Rather than when we're talking about post-infective illness, we're in a situation where we're talking about an unexplained situation of the symptomatology, and that persists. I mean, it's unexplained, it's becoming more and more explained, but at least there's not a sort of how do you say that, a single event that explains that the person is actually sick. And I haven't shown, but we have a great graph that actually shows this framework where when you have a medically explained condition, you cannot go through anymore through a long COVID designation. And I had a lot of difficulty to accept that. I remember I was like, oh, no. I was really annoyed at that because, and I still think sometimes, even if I'm convinced to some extent now, I still think sometimes maybe people have exacerbation. And I've asked that question just before the talk to Carolina, exacerbation of an ongoing or concurrent illnesses. And Carolina said to me, well, it depends what you're talking about, which illness you're talking about. And that's also where some of the answer is. I hope I answered your question correctly. I mean, satisfactorily. But Andrew wants to say something more, and I will let him, please, Andrew. Andrew is our mentor.
Just one brief follow-up comment about the intent, I guess, picking up on Tony's comment, and that is that for research purposes, if we want to do some biomarker or pathophysiology study, we have to have apples and apples, not apples and oranges. And so pulmonary emboli after intensive care, that's oranges. We're interested in the apples. And so we're trying to separate the apples and the oranges, the wheat from the chaff kind of thing. The other thing I was going to do is ask Lucette a question. So, AI is the buzz topic.
Yep.
And so it looks like you've done a whole heap of work trying to sift through all these publications and studies. Can't you just get AI to do that these days?
Well, yes and no. Yes and no. So you know what? It's interesting because I was just I received and I don't want to do any advertisement for any particular software here, but I received an email from one particular one, and they're saying they've just improved their system to look at even more databases. So in other words, yes and no. So it can definitely help you to cipher through things, but you still need that expertise level knowledge to make sense of what it says. And then what I understand from this as well, there's different capacities. So for that particular software, when you pay for the highest level, it's going to do probably a very good job, but the free tool do not a very good job at all. Yeah. So it depends also on the amount of literature. So when we looked at with Ryan, when we looked at the acute, the research that look into acute symptom, we knew already the answer. There was almost no studies. So that was easy. That confirmed that. But when there's a lot of knowledge, and especially if the knowledge is a little bit contentious or complex, the AI needs to be guided like a junior student.
We've got an online question, Lucette. I'm going to try and help you out here. So the online question is, if the PCR tests negative, but the patient continues to experience symptoms of acute COVID-19, or let's say continues to experience symptoms of COVID-19, is it long COVID? That was the first question.
Well, so what I would do in that case, so, and we all know that's possible, so we can, I remember some people, especially young people, they would test, and they were definitely, or my sister actually tested, she was really, really sick, went to test for COVID PCR back in France, and she was negative. And I said to her, do retest, because you needed to retest. And I was the expert there saying to her, you need to go back in a few days, you'll see, the virus is going to be all over. And she was positive 3 days later, and very positive. And so you need to test again, that's my answer. Yeah. And if you test negative, like 3 times in a row, this is not long COVID, this is something else. Yeah.
But it could be another acute infection that they were sick with.
That's it. It could be, or it could be God only knows what. Yeah.
I don't understand the other half of the question, but maybe you can elaborate. So
the definition described here were common in our 35 interview and 15 FGD. I was wondering if there is a specific list for this review.
I don't know what FGD.
Yeah, I'm sorry. There's a question there online. We're not sure what FGD refers to. Yeah.
Maybe they can email you and ask.
Yeah, you could email us and ask. Yeah, that would be fine. So the APPRISE definition is online, and I think there's some work internationally. I don't know if I should say much about that, Andrew, but there's some work intentionally to come with something that will encompass so the frameworks and applies to long COVID, and that will come in the next few months, I think, and that will be published online at some stage. So we'll keep you posted on that. And I think, it probably be a reference in terms of looking back at post-infective illnesses, because it looks at, what I said, what was in the background, takes long COVID, and also looks toward the future, I'm pretty sure.
Can I ask one question,
Yeah.
Lucette? So you've got a very strict definition and using lots of tools and a structured clinical interview. How confident are you, or how doable do you think it is for a patient to get that type of good comprehensive assessment in primary care? Or do you think it's tricky, or do you think it's possible? Or, and if a GP says, I'm interested in knowing how to do this, what would you?
Yeah, my experience is with GPs, maybe it's a bit biased because we get the ones that are the most interested in the study, but I can talk about my own personal GPs, etc. When I mentioned the study, they're very interested. And the reason is because, and they say they can do it. And the reason is because when they have to deal with this type of patient, they actually want to help, and they want to be able to follow what's the best guidance that's out there. So when people have access to that best guidance, and I think it's been put out by Andrew and yourself, actually they go through this process, and it does help people. They get either recognized for what they have and then helped, or if they have another medical condition that needs to be treated, they get helped as well. Like I was talking about the case of sleep apnea. And then so everybody's thinking, oh, what about if we don't know what's going on? Well, I think there's always the possibility that doctors faces that situation where you have a patient that you're not sure what's going on with them, but at least you have this baseline assessment where everything was done, and there's a change from there. You can still also intervene if needs be. So at least the person is under a monitoring framework, in other words. Is that a good answer? That was a bit of a,
answer.
I think that was a trick question.
There's no other questions, and we might just thank Lucette. Thank you very much.